Hello. Aphasia is a language disorder caused by brain damage, usually to the left hemisphere, and its core features are impairment of word production and auditory comprehension. Aphasia is distinct from motor speech disorder and peripheral hearing loss, and in its isolated form, non-language cognitive functions tend to be relatively spared. There are progressive variants of aphasia, which are associated with frontotemporal dementia or Alzheimer's type pathologies. And in these cases, in contrast to the typical decelerating recovery curve that we see in stroke and other sudden onset etiologies, cases of primary progressive aphasia worsen gradually over time with increasing involvement of non-language cognitive functions as the disease advances. However, regardless of type, aphasia profoundly affects psychosocial functioning, life participation, and overall well-being. Aphasia is more common than some better-known conditions, including Parkinson's disease, with current prevalence in the U.S. estimated between 2.5 and 4 million individuals. This estimate does not include primary progressive aphasia, which is rarer, with an estimated prevalence similar to ALS. Stroke is the most common cause of aphasia, followed by traumatic brain injury and brain tumor. And compared to cases of stroke without aphasia, the condition is associated with increases in many healthcare utilization metrics, including length of stay, readmission rates, and office visits. And adjusting for inflation, based on a study of Medicare payments made in 2004 that compared stroke patients with and without aphasia, we can estimate that aphasia results in roughly $4 billion annually in additional Medicare payments alone. The psychosocial consequences are also enormous and include increased risk for depression and social isolation and reduced employment. And in one study, among 75 health conditions, including cancer and Alzheimer's disease, aphasia was found to have the greatest negative impact on an indirect multi-component measure of health-related quality of life. Turning to the clinical presentation and course of aphasia due to stroke, the extent and location of the lesion are generally predictive of recovery. These figures, taken from a recent investigation by Wilson colleagues, show lesion overlays and overall aphasia severity measured acutely and at 1 month, 3 months, and 1 year post-onset. The main points here are that recovery is usually good, if incomplete, for small lesions involving only one lobe of the brain, and that the worst outcomes are seen with the larger lesions shown in panels G and H involving the posterior or the entire parasylvian region. Also, consistent with other recent evidence and thinking on aphasia, this study provided no empirical evidence, let alone any predictive or explanatory role for dichotomous distinctions between fluent and non-fluent or receptive and expressive subtypes of aphasia. Rather, the various subdomains of speech and language that contribute to fluency, expression, and comprehension are supported by the whole language network with varying degrees of redundancy, and they tend to be impaired and to recover gradually in tandem. In the 1990s, aphasia care in the US was dominated by approaches that focused on treating the underlying cognitive linguistic impairments. These approaches emerged from a variety of theoretical orientations and have lately coalesced around principles informed primarily by psycholinguistics and the cognitive neuroscience of language. They tend to be targeted at restoration of function, but can also work by compensatory mechanisms. The organizing principles include linguistic domains such as phonology, syntax, and semantics, and factors known to influence neurorehabilitation outcomes more generally, including treatment intensity and overall dose, avoidance of learned non-use, and salience. While impairment-focused approaches to aphasia rehabilitation arguably still dominate the practice patterns of most providers, in the late 1990s and early 2000s, clinical aphasiology began to better integrate the view, referred to as the life participation approach to aphasia, that aphasia treatment must also directly address the psychosocial consequences of the language impairment. This integration was motivated in part by the 2001 adoption of the International Classification of Functioning Disability and Health by the World Health Organization as an organizing framework. It was also influenced by the shift away from fee-for-service payment models and associated reductions in authorized payments for aphasia rehabilitation, by growing evidence for the efficacy of group treatment, and by a desire to push back against the contemporary trend redefining functional communication as nothing more than the ability to communicate one's basic needs. This slide provides some examples of aphasia treatments drawn from both impairment-focused and participation-focused traditions. Semantic feature analysis is perhaps the best studied treatment for word production and is quite effective at improving production of trained and to a lesser extent untrained but semantically related words. However, there is little evidence that it generalizes to everyday conversation or to other kinds of discourse. There has been a lot of interest in intensive constraint-induced aphasia treatment, which focuses solely on spoken expression for the past 15 to 20 years, but a recent large, high-quality RCT found that it performs similarly to multimodal aphasia treatment. And among the participation-oriented treatments, Communication partner training has been shown to improve the quality of conversations between persons with aphasia and their partners, and educational efforts based on this approach are an important key to improving communication access for persons with aphasia more generally. Also worth mentioning in this context are current efforts to extend evidence-based counseling approaches to address the psychological needs of persons with aphasia, including a current NIH-supported trial of acceptance and commitment therapy for aphasia being conducted at the University of Pittsburgh. On the question of treatment efficacy, a 1998 meta-analysis of 55 quasi-experimental studies found that treatment compared to no treatment produced effect sizes that were on average twice as large as untreated recovery in the acute phase and half again as large in the post-acute phase. A more recent Cochrane review that included data from 57 RCTs found positive effects of treatment, greater benefits of interventions with higher intensity, dose, and duration, and a need for higher quality evidence. A more detailed analysis of individual patient data yielded specific findings that total treatment dosages exceeding 20 to 50 hours, treatment frequencies of 3 to 5 visits per week, and treatment intensities of 4 to 9 or more hours per week produced the best outcomes. However, these findings should be interpreted cautiously because of the potential influence of spontaneous recovery, which was not controlled for, and because of the statistical challenges associated with aggregating different outcome measures across many data sets. Moreover, 2 recent large RCTs have failed to find an advantage for intensive treatment over usual care or delayed treatment in the acute phase of recovery. And other recent meta-analyses have been more equivocal about both overall dosage and intensity in the post-acute phase as well. Our own unsystematic synthesis of this literature is that more treatment is probably better in many cases, but the error bars are wide, and the effect likely depends on many factors. Also, to be clear, the dosages and intensities specified here are those that can be expected to produce a robust effect on overall aphasia severity or some targeted outcome in a single episode of care. They should not be taken as recommendations for the lifetime needs of a person with chronic aphasia. In any case, a recent scoping review and comparison of treatment dosages in the published research literature with those obtained from outpatient electronic medical records at the University of Pittsburgh Medical Center found that clinical care was associated with significantly lower dosages and intensities across all variables examined. While this study was limited to one regional, albeit large, healthcare system, it does suggest that whatever the marginal effects of dosage and intensity are, the treatments delivered in typical clinical contexts are not consistent with the treatments described in literature. On the issue of costs and payments for traditional outpatient service delivery models, CMS typically covers aphasia rehabilitation services along with physical and occupational therapy under Medicare Part B. The cost of a single aphasia therapy session varies with location, session length, and treatment method, among other factors, with the average cost ranging from $100 to $250 per hour. Under Medicare Part B, CMS reimburses 80% of the approved amount, and the remaining 20% is paid by the patient unless they have supplemental insurance. And in the example provided here for Pittsburgh, one can see that after allowing a minimal 2 to 3 hours for assessment, which needs to support diagnosis, treatment planning, and baseline measurement, an individual will be left with roughly $1,800, or not quite enough for one course of the average individual treatment dose reported in the literature if they have no other rehabilitation needs. The data presented on the previous slide also suggests that persons with aphasia in Western Pennsylvania are using less than half this amount for their aphasia rehabilitation. Furthermore, this analysis ignores the fact that almost all persons with aphasia will finish a course of even the most effective treatment with persisting disability and thus continued need for services. This leads us to a discussion of 2 other prominent service delivery models for aphasia care. The first of these is the Intensive Comprehensive Aphasia Program, or ICAP, which combines the philosophical orientation of the ICF with the principles of experience-based brain plasticity grounded in neuroscience. The term ICAP was coined in 2013 by Rose and colleagues who established 5 criteria based on intensity and dosage, treatment type and targets, the inclusion of educational programming, and program structure. Based on an updated 2022 report, the number of these programs appears to be growing both globally and in the US, and the National Aphasia Association website maintains a list of them for North America. To provide an example of one such ICAP, in 2009, to increase access to high-quality aphasia rehab care for veterans, the VA Pittsburgh Healthcare System Audiology and Speech Pathology Service, in collaboration with the VA Pittsburgh Geriatric Research Education and Clinical Center, established PIRATE, the Program for Intensive Residential Aphasia Treatment and Education, which accepts referrals of veterans and active duty personnel nationwide. Initial evaluations are typically conducted via telehealth, and accepted veterans travel to Pittsburgh, reside in community-based housing, and are seen for 5 hours per day for 4 weeks of individual and group treatment and educational programming. We typically run 6 sessions per year, and to date, the program has served over 220 persons with aphasia. Also, since the pandemic began in 2020, we've run 7 sessions serving 19 veterans via telehealth, with outcomes comparable to those observed for standard in-person PIRATE. We published outcomes for our first 73 participants in 2014 and showed statistically robust effects on overall aphasia severity, discourse production, and patient and surrogate reported communicative functioning as measured by the Aphasia Communication Outcome Measure, a PRO developed with VA R&D funding. Positive effects were maintained at follow-up, and a recent analysis of the outcomes for fiscal years 2016 through 2022, including an additional 92 veterans, produced similar results. One other component of PIRATE also bears mentioning. From 2012 to 2018, we hosted a biennial PIRATE Summit, which functioned both as a one-day seminar and a resource fair for persons with aphasia and their significant others and clinical providers, and also as a social reunion for former PIRATE participants who have flown into Pittsburgh from as far away as Alaska for the event. The 2020 summit was canceled due to the pandemic, and we have plans to resume the meeting in 2024. Considering the cost of the core PIRATE program, we estimate that VHA pays at least $11,000 per veteran for PIRATE. This estimate includes approximately $7,700 in staffing costs and an additional $3,700 in housing, but doesn't include overhead and infrastructure, transportation, or other incidental expenses. And while the expenses associated with private sector ICAPs are reported to be similar, the out-of-pocket costs to clients are not, with self-pay being the modal source of funding for US ICAPs and charges of $10,000 to $20,000 or more being common. And this brings us to the third service delivery model that I'm going to talk about today, which is aphasia community centers and groups. These are organizations that range from informal, volunteer-led monthly support group meetings up to freestanding nonprofit organizations with annual budgets of $1 million or more. Some of them are also housed within university academic departments and affiliated with their clinical training and research programs. The first one in the United States was the Aphasia Center of California, founded in Oakland in 1996 by Roberta Ellman. The number of these organizations has increased markedly since the turn of the century, and the non-representative samples shown here are simply the ones that I've interacted with over the course of my own career. This slide comes from a 2021 annual report published by the Adler Center, which is one of the largest aphasia centers currently operating. They offer programs throughout the state of New Jersey, and their largest expenditure is on a life skills program for persons with aphasia that operates at their main campus in Maywood and charges members $1,000 for 15 weeks of 8 hours per week programming that includes discussion groups, technology sessions, performing arts and wellness activities, and supported aphasia advocacy projects. Over half of the revenue comes from individual donations, with foundation and corporation grants and government grants coming in a distant second and third, respectively. Close to the other end of the spectrum is the Aphasia Support Group operated by the University of Pittsburgh Department of Communication Science and Disorders. This group, whose budget consists of a 7.5% FTE speech-language pathologist plus a few $100s in supplies, meets monthly at a university community engagement center located in the Homewood neighborhood of Pittsburgh. It started as an online group in the spring of 2021 and currently draws 15 to 20 people per month to in-person meetings for educational presentations and discussions of topics of interest to the group members. And I'll close the presentation with an abbreviated list of unmet needs of the aphasia community. For more depth on this topic, as well as many other points that I've talked about, I should say highly recommend Nina Simmons-Mackey's excellent 2018 white paper, Aphasia in North America, published by Aphasia Access. The needs listed here can be summed up by the phrase communication access. Just as individuals with limited mobility need and deserve accommodations to make the physical environment more accessible, persons with aphasia need and deserve communication accommodations to make the social environment more accessible. These accommodations can be developed first and foremost by educating healthcare providers and the wider public about aphasia and how best to communicate with individuals who have it. And I will say, it seems like that we're seeing progress on this front. The 2022 National Aphasia Association Aphasia Awareness Survey found that 40% of respondents could identify aphasia as a language disorder, up considerably from only 7% in 2020. Persons with aphasia also need expanded access to counseling services, especially given that aphasia is a known risk factor for depression and social isolation. Greater funding is also needed for community aphasia centers, which are relatively low-cost approaches to helping persons with aphasia develop and maintain the kinds of social contacts that are necessary for health and quality of life. Finally, there needs to be greater attention paid by speech-language pathologists to participation-level outcomes and by researchers to figure out how to better promote generalization of aphasia treatment outcomes to conversation and other kinds of real-world communication. Thank you for your attention.